I'm Mick Kumwenda. I'm a nephrologist, and I do a lot of diabetes in the UK. I've been asked to talk about cardiometabolic renal disease this morning with you. And big thank you to Ines and faculty of the ASD for invitation, particularly to celebrate the 21 years of excellent presentations in the past 21 years. So the bigger picture is that the main problem we have is cardiovascular, kidney metabolic health. And I think the definitions have changed depending on what you have read about. But from what I understand is that this is a combination of cardiac, renal complications associated with diabetes. And as such, then we'll be talking about atherosclerosis, which is in general cardiovascular disease, which encompasses these four components of vascular disease on the left-hand side. So it can be a combination of cardiometabolic renal disease, can be a combination of obesity, hyperlipidemia, hypertension, insulin resistance, pre-diabetes, diabetes, non-fatty non-fatty liver disease, non-alcoholic fatty liver disease, chronic kidney disease. And there's also another definition, which is cardiorenal syndrome. Now, cardiorenal syndrome is a combination of chronic kidney disease with chronic heart failure, but you don't actually find primary disease when you look for cardiac causes. There's no ischemic heart disease, and when you look for chronic kidney disease, you don't have any primary renal cause for the CKD, and then the two of them kind of feed into each other as a circuit. CKD causes CCF worse, and then CCF makes CKD worse over time. The key thing is that if you look at the global causes of death in the last 2 decades, 1990, 2021, published in the Lancet, you'll see that at the top of the list is ischemic heart disease, leading the causes of death in the world. And then if you look at diabetes and hypertension and CKD, they're in the within the top 30%, but they've changed positions. You can see here diabetes at number 14 in 1990, and that's gone up to number 10 in 2021. And same thing with the CKD, again moving positions. Chronic kidney disease was number 18 in 1990, and that's gone up to number 11 in 2021, suggesting that actually the prevalence is increasing over time, making it a very important cause of death in the world. So how do we tackle this problem? I think to tackle the problem and to manage it properly, we have to understand some of the pathophysiology that goes on. And firstly, you are well aware of the influence of the renin-angiotensin system. As you recall, renin is released from the kidney in response to change in the perfusion pressure, and then that converts angiotensinogen to angiotensin 1, and then through several mechanisms produces angiotensin 2. Now, angiotensin 2 has a physiological influence of the whole of the cardiovascular system. It is a potent arterial vasoconstrictor that increases blood pressure when you need it. It promotes aldosterone secretion from adrenal gland, which increases sodium and water retention. Again, this is essential for normal physiology, and it leads to antidiuretic hormone secretion from the pituitary, which again increases water retention and increases sympathetic activity that is needed to increase your heart rate and blood pressure, for instance, when we are exercising. All very well in physiological status, but when this system is overactive, then it produces the opposite effects, whereby you have constriction of the blood vessels, and then sodium, water retention, causing hypertension with the kidneys as well as heart failure, and the whole thing then feeds into each other, causing a circuit that you need to break with medication, otherwise the patient gets worse over time. And in terms of diabetic kidney disease, again, this is a slide just to show you how it works, what processes are going on to produce the problems with renal damage. If you remember, the glomerulus has the efferent and arterioles that feeds blood into the glomerulus and takes blood out. And on the efferent side, the vasoconstriction is maintained by the arterial vasoconstrictors, angiotensin II, endothelial 1, reactive oxygen species, and thrombexin A2. And on the opposite, on the afferent side, you have insulin resistance, COX-2, prostanoids, kallikrein-kinin system, which then causes vasodilation. And this pressure difference between the arterial and the efferent arterial will then maintain glomerular pressure. But when you have any influences that causes increase in efferent vasoconstriction, then the pressure gradient increases in the glomerulus, and that tends to affect glomerular filtration rate as well as glomerular function, which then activates all these pathways that I've alluded to on the left side, causing to cause problems with podocyte loss and fibrosis of the kidney over time. And in particular, hyperglycemia can cause these processes to be activated. So you get formation of advanced glycation and end products, release of transforming growth factor beta, which is a pro-fibrotic factor, and aging of the endothelial progenitor cells, and podocyte injury. And podocytes are essential for the function of the glomerular basement membrane, which is responsible for all the filtering that happens in the glomerulus. And over time, the podocyte injury will cause loss and then deformation of the basement membrane, causing problems with renal function over time. So there's this incredible interplay between CKD and heart failure in diabetes. There's an sympathetic nervous system activation caused by impaired glucose homeostasis via stimulation of alpha-adrenal receptors, which enhances lipolysis, elevating free fatty acids and promoting hepatic gluconeogenesis, and impair insulin secretions from the pancreatic B cells. The whole thing is obviously mediated as well through the renin-angiotensin system that we have already alluded to. So what do you do about it? And this is just a publication that came out in 2023, and this is the president of the American Heart Association put a group of scientists to say, look, can you sort this out? Can you first of all work out what is the key problem? How are we going to define it? And what is it we should be doing to try and control this problem? Because as you know, it is just escalating around the world. So they've come up with a definition of cardiorenal syndrome, which is a health disorder characterized by interconnections between obesity, diabetes, chronic kidney disease, and cardiovascular disease. This includes conditions such as heart failure, atrial fibrillation, coronary artery disease, stroke, peripheral artery disease, and cardiovascular kidney metabolic health encompasses a syndrome that individuals at risk of cardiovascular disease, as well as those that already have existing vascular disease. And so they came up with the definition of pathophysiology. They looked at the strategies on how we can manage this condition and come up with some guidelines as far as how we can all standardize the treatment and optimize the treatment for these patients. So they staged cardiovascular health metabolic disease into 4 stages. Stage 1 was very little risk, and therefore you focus on primary prevention and good health, so exercise, good diet. And then stage 2, there's problems with physical dysfunction, particularly influence from obesity. And then stage 3, the patient who then have excess adipose tissue or obesity, they have metabolic risk factors and CKD, hypertension. And then stage 3, subclinical cardiovascular disease, the beginning of coronary artery disease. And then stage 4, this is the full-blown combination of the clinical conditions that I have mentioned, such as coronary heart disease, heart failure, stroke, peripheral vascular disease, atrial fibrillation. And these individuals also present with excessive dysfunctional adiposity over the other risk factors that I have mentioned. So stage 0 to stage 4, and therefore we should be focusing those patients at risk right at the beginning of this syndrome, addressing all the cardiovascular risk factors to target so that the condition does not progress to the stage 4. At this point, the mortality risk is extremely high. So in the future, this is the model that we should be thinking about how to deal with cardiometabolic disease. And this is a multidisciplinary strategy where we have psychologists helping us with behavioral processing and encouraging the patients to live healthily, exercise, proper diet. And then we should have groups that are giving us some epidemiological studies so we can see the trends, the problems, and start working out policies how we can reduce the cardiometabolic renal disease. And then we should have nutritionists in the system. We should have public health, psychologists, all working together with diabetologists, cardiologists, nephrologists, pretty much all the ologies that cardiovascular disease, cardiometabolic disease are involved with. So this is a complex clinics, complex health professionals coming together to look after the patients and provide the skills that are required to treat them. So in terms of targeting the actual management of cardiometabolic disease, it's actually very simple, as you already know about it, and it's focusing mainly on the angiotensin, renin-angiotensin system, firstly using ACE inhibitors or angiotensin II receptor antagonists. And as I said earlier, these drugs try and reduce the efferent constriction that is causing excessive production of angiotensin II, causing interglomerular pressure to rise and therefore affecting glomerular filtration rate and eventually going into CKD. Initially, when you start these drugs, you'll see a transient rise in creatinine, but it tends to stabilize within a few weeks. So you may see 10 to 15% reduction in EGFR. Please don't panic. Carry on with the same dose, and you'll see that it then plateaus or it reverts to baseline. And the SG2 receptor antagonists are affecting the arterial, the afferent arterial, causing vasodilatation and therefore maintaining glomerular pressure. Again, working in a similar way to the ACE inhibitors, you may also see a transient increase in creatinine that tends to stabilize over time. And this is another facet in the management where we use mineralocorticoids to try and reduce the progression of the CKD. And this has already been shown very neatly with two studies, the Fidelio CKD and Figaro DKD study. As you can see, they split into two groups, placebo versus intervention, and over time you can see the results on the right hand side showing the benefit of addition of phenylalanine to management of these patients with CKD and heart failure. And again, this is another study, a meta-analysis of all the studies of influence of GLP-1 receptor agonists on patients with cardiovascular mortality and kidney outcomes. Again, you can see here benefit in the patients that receive GLP-1 receptor agonists. So renal disease in combination with diabetes requires this multifactorial approach, focusing on the four pillars that I have already described. But I think in general terms, we know that this combination of the four approaches works very well. And again, this is a meta-analysis of the studies where they have combined ACE inhibitors, SGLT2 receptor antagonists, and GLP-1 agonists, as well as mineralocorticoids. Again, you can see the benefit of all the studies that were reviewed in the meta-analysis. And eventually, we've also got CKD in combination with diabetes colleagues in the KDIGO clinical practice guidelines in terms of what we do with these patients with cardiorenal syndrome in terms of providing lifestyle modification, and first-line drugs can be metformin or SGLT2s, and then in addition you give these patients GLP-1s and mineralocorticoid over a period of 3 to 6 months. Make sure they are all on this group of drugs to try and control the progression of diabetic kidney disease. But I think four-pillar approach is all very well, but we should not forget the influence of cholesterol. There's studies out there to show that hypercholesteremia can worsen the progression of diabetic kidney disease, and the drugs that are used for control of cholesterol are also applicable for CKD, and except perhaps you have to be careful with the use of fibrates when you're trying to control hyperglycemia. So in summary, ladies and gentlemen, I've rushed through all the slides this morning to satisfy the chairperson, so I don't go over time. But in summary, cardiorenal syndrome is a component of cardiovascular kidney metabolic health and encompasses the intricate relationships among metabolic risk factors, chronic kidney disease, and cardiovascular system. Poor CKM health can lead to significant adverse clinical outcomes, particularly cardiovascular mortality and premature mortality. There's several increased opportunities for us to use therapies to treat aggressively risk factors for primary prevention as well as secondary prevention in terms of progression of cardiovascular disease for the patient. Establishing clear definition and staging of a framework of CKM syndrome is essential to enhance CKM health and improving related outcomes within the population. So, ladies and gentlemen, we have now got a complete picture of the framework of a cardiovascular diabetic kidney disease that is now a very, very high-risk condition for our patients. Thank you very much for your attention.
Thank you, Professor Mick, for this elegant presentation. Professor Mick demonstrated the relationship between heart and kidney in people with diabetes, and how the heart affects the kidney, and how the renal disease affects the kidney, the heart. Also, he demonstrated the management of diabetic kidney disease and how the targets of treatment have been changed in the last years, just from ACE inhibitors and diabetes control, or RAS blockers and diabetes control, to the recent drugs as insulin glucose transporter 2 inhibitors and GLP-1 receptor agonist. And thank you for your nice presentation. If you have questions from the floor or virtual, if you have questions virtual. Thank you.